Thanks for meeting us at the Canadian Breakpoint, a Canadian infectious disease podcast by infectious disease physicians. I'm Summer Stewart, here with Dr. Rupeena Purewal, pediatric infectious diseases specialist from Saskatoon. For this episode, we welcome Carley Pozniak, pharmacist with the Saskatoon Positive Living Program, to review game-changing, novel HIV antiretroviral, Cabenuva. Welcome, Dr. Purewal.
All right, so welcome to another episode of our podcast at the Canadian Breakpoint. Today, we have a very special guest, Carley Pozniak, who's a pharmacist that's worked with Positive Living Program since 2017 here in Saskatoon, Saskatchewan. She is a part of an interdisciplinary team that provides care to people living with HIV and hepatitis C. Aside from providing care to her wonderful patients, she enjoys sharing her knowledge in this area by precepting pharmacy students and residents each year. She's also an active member of the Canadian HIV and Viral Hepatitis Pharmacist Network, CHAP, which is a group of pharmacists that collaborate together on various projects and publications. She's currently serving on the executive team as the CHAP secretary. So today, she's joining us to talk a little bit about a new novel way that patients can receive their antiretroviral therapy for HIV in the form of injectables. So I want to welcome Carley today. And I actually know Carley very well because we work together here in Saskatoon. So she's done a lot of work with pediatrics as well as adult HIV. So thanks, Carley.
Thank you for having me.
Perfect. So I want to start off with, I think a lot of us clinicians aren't really aware of Cabenuva. So that's what we're talking about is our HIV injectable drug that was recently put on the market. So I think for kind of a broader range of knowledge, because most of clinicians, including myself, who is an infectious disease specialist, but haven't dealt with Cabenuva much. So I think why don't we start off with just giving us a little bit of a background, as in what is Cabenuva and when was it put on the market, and some of the indications and contraindications that we should be aware of.
For sure. So as you said before, it is a brand new delivery form that we can use for patients in antiretroviral therapy. It's given by intramuscular injection into the buttock region. So there's one injection per buttock. So there's basically two shots. And it contains two drugs in it. Traditionally, we've used 3 antiretrovirals in a regimen. This one has 2. And one of the meds is called Cabotegravir. It's an integrase inhibitor. It's the newest in that class. And then the other medication we've had around for a while, it's called rilpivirine, and it's one of the non-nucleoside reverse transcriptase inhibitors. So with this injection, because it's given in the buttock region, it does have to be administered by a healthcare professional. So that can kind of limit, patients can't just take this home at the moment and administer themselves. So it does, require a certain amount of coordination with a site that is able to provide it and administer it. It first came out that it could be given every month, and then later on they approved every 2-month administration as well. So I think this is a huge advance for antiretroviral therapy because we're starting to get into kind of more long-acting formulations, so just more options for patients to choose from instead of maybe like the daily grind of taking pills. Someone might want to look at this route. So.
Yeah, so I think you touched on a really important topic there is, I think the ease of taking injectables versus taking daily medications. And so I think that's probably what made me more excited about it because I know, and we'll probably talk a little bit about eligibility, and I'm not sure how it is in the pediatric world yet, but you can probably give us some information in regards to that, I'm sure today. But I think really looking at, quality of care for patients, I think, managing HIV patients myself, I find that compliance is sometimes an issue, especially in our teenager groups, right? And then, life gets hard, right? So with COVID, a lot of people can't even get access to care. And I know here in Saskatchewan, HIV has really skyrocketed in terms of our numbers during the pandemic, and whether it's probably multifactorial, but I think it's something that drugs like this may help us curb that in the near future. So what are, in terms of you mentioned the true drugs, why don't we talk a little bit about the indication for it? So what is like the ideal patient for this? And you can talk a little bit about eligibility, for us clinicians to know kind of when to contact who.
Great. Who are we targeting here? So presently it's indicated for treating HIV-1 infection, and just in adults though, ages 18 to 65. And I can talk a little bit more in a minute as well. They do have a trial ongoing in 12 to 18-year-old patients. So I know as a pediatric infectious disease physician, probably very interested in that cohort. So we can talk about that. Basically right now it's sort of considered like a switch therapy. So the patients do have to be suppressed on antiretroviral therapy prior to initiating the injection. So we're looking for the patient to have less than 50 copies. In the trials that looked at this form of antiretroviral therapy, most patients were actually suppressed for 6 months or longer before they actually initiated the injectable. Not to say that you have to do that, I guess, in practice, but it does kind of promote a sense of, that the patient is stable, getting their medications regularly and can kind of commit to something like this as well.
Right.
So in the beginning, right now in Canada, in Europe, they've kind of taken the oral lead-in phase out. They've taken that off the product monographs. You don't have to. There is evidence to skip that. But right now in Canada, there is an oral lead-in phase with the oral form of Cabotegravir and rilpivirine that's given for 4 weeks. And the only purpose of doing that was to assess if there was any hypersensitivity reactions. And at the EECS conference in the fall, they actually presented some information about that. And it has been found that there hasn't been any increase in hypersensitivity reactions. They've gone ahead in Europe anyway and removed that kind of, I guess you call, restriction. But in Canada, if you're kind of going with the label, it's basically giving the oral form of Cabotegravir and rilpivirine daily for 4 weeks. Now, in some of our patients, we have considered going kind of off-label, I guess you'd say, and if they're on a regimen, they're suppressed, just switching right from that to the injection.
Okay.
And the reason for that is, one, you're getting extra kind of medication switches, so it kind of involves, more follow-up, more blood work, potentially more confusion for the patient. Rilpivirine orally does participate in a lot more drug interactions. So if anyone's on an antacid or something, an acid reducing medication, you can compromise rilpivirine there. And again, for rilpivirine, it is required to be taken with a meal. So for some of our patients in Saskatchewan, for example, who have food security issues, it's probably not a good approach to take for them, that, to say you have to take this with a meal, every time you take your oral meds, that's just not feasible for some of our patients. So there are a few, I guess, reasons why we might consider skipping that oral lead-in phase if we're wanting to get someone going on the injectable. And I guess the perfect patient would probably be someone who's going to be able to commit to regular injection appointments and follow-up, and has kind of shown a track record of being stably suppressed. The biggest consideration, I guess, in that respect is that because this is an injectable medication, it has a really long PK tail on it. So once you have an injection of Cabenuva, it can actually last in your system for up to 12 months. So wow. If someone, gets an injection and then decides, no, I'm not going to go with this, they are committed to taking oral medications thereafter for at least 12 months regularly to prevent developing 2-class resistance with Cabenuva. So integrase inhibitors plus the non-nuc class could be completely wiped out potentially. So that's definitely a consideration that, something to talk about with patients when considering this as an option. Just making sure they're aware of kind of these ins and outs before they commit to it, I guess you'd say.
Right.
Mhm.
And currently this is a monthly injection, right?
It is monthly. They have approved in Canada to give it every 2 months.
Okay.
I would say for our patients, I lean more towards doing the monthly injections to begin with. Just so you can kind of build up that steady state. I think there'd be a little bit less risk of having any viral breakthrough. And then maybe after 6 months or so, you could, if the patient wants to go to an every 2 month schedule, I'd probably consider it at that point. You can, if the patient is suppressed, you can go right to the every 2 months, administration schedule. But I personally kind of like to stick with the every month and, see how that goes.
Okay. No, that's for sure. And in terms of, I know you mentioned like some of the contraindications or some of the things that we should think about when we're putting these patients on some medications. Are there any comorbidities, like if they have liver dysfunction or renal dysfunction, anything like that, that we should be aware of as clinicians?
For sure. So if anyone has a creatinine clearance of less than 30 mils a minute, or if they're on dialysis, or if they have liver failure, so if they're at the Child-Pugh C level, I wouldn't consider Cabenuva for those patients.
Okay.
Same with if they have a chronic Hep B infection. Cabotegravir and rilpivirine both don't provide any coverage for Hep B, so you could have a flare. In the trials, they did have that as an exclusion criteria, but I think there was one or two that somehow they weren't aware that the patient had Hep B and made it in there, and they had a flare. So definitely making sure you're aware of their Hep B status and looking that ahead of time. And, do you need to have tenofovir in their antiretroviral regimen to help control that? So in terms of other contraindications, there were some treatment failures in the trials. So, and this is, people who have perfect adherence, they're in a study, there's, we're not having missed appointments, that kind of thing. And it kind of varied from 1 to 1.7% of a failure rate in people who were taking it perfectly. And what they did find, they kind of looked into that a bit more to see, well, what was happening with those particular patients? Why was there a breakthrough? They found people that had clade A or some type of A virus. That was a factor. Now, we don't have a lot of that in North America. That's probably a subtype you'd see more in Russia. So it's probably not something we'll run into kind of in our neck of the woods here. The other thing they found, if the patient had a BMI that was greater than 30, and then also if they had any resistance associated mutations, that they tried to screen for that ahead of time, of course, but sometimes there's something that's lurking in the background. So it was kind of a combination of all three of those that seemed to predispose people to having confirmed virologic failures on this regimen. Now with the BMI alone, if that's the only factor in the mix, that they're above 30, that didn't increase the risk of failure. So you can still consider patients with a BMI greater than 30 to be on this medication. But
and does the BMI kind of I'm just going back to thinking about like other injectables or anything like that when we talk about any injectable medications, does it relate to kind of the distribution, like the distribution of the drug? Is it a certain site that we're injecting that makes it difficult for those that have a BMI of greater than 30?
I think something that can come into it a little bit, they presented in the fall that people with BMIs greater than 30, they recommend a longer needle. So it might be the fact that maybe it wasn't quite getting into the muscle in some of those folks too, or not completely. So that's something they do recommend. I think it's a 2-inch length of needle that they recommend you use. So with the Cabenuva package, there are needles and everything that come with it, but if you do need the longer length of needle, you'd have to get that ahead of time for the patient. So that's something that kind of came out with that, but yeah.
Okay. All right. And I think I'm understanding a lot about the indications and the contraindications and really like what an eligible patient is. Even whether you're taking care of this patient in the community setting or in the hospital, like obviously most of the HIV patients will be managed by subspecialists. And So this obviously information is really, really good for us too. Obviously for me, a little premature because it hasn't been approved in the pediatric population yet, but definitely something to consider, especially when we're doing transition of care, right? So from transferring patients over to the adult side, something to consider. So whenever a new drug comes out, we always think about costs, and that's a important thing. Is there a cost to the patient here? What type of coverage? And I guess we'll probably know a little bit more about the Canadian healthcare system in terms of that, and probably if you can touch a little bit on that, that would be great.
Yeah, for sure. Like you said, it's going to vary kind of where geographically the patient is located, but even in Canada, from province to province, it can vary a little bit. But in Saskatchewan, for example, the provincial formulary did add it on, and we do have universal antiretroviral drug coverage here. So that means any antiretroviral they add to our formulary, it'll be 100% covered to the patient, for the patient, no cost to the patient. The other, I guess, thing to consider too, anyone who has NIHB coverage. So that's a federal program. So anyone who has treaty status and is eligible there for coverage, it's covered for them 100% as well. So it kind of depends if the province the patient is living in has decided to add it onto the formulary. I know a few provinces in Canada have added it already, but there's still a few more that are probably considering it. I think most probably will end up adding it because it was, I guess, negotiated to be kind of a similar price to other regimens. So it's really not going to cost more than kind of our traditional regimens, which is good. We don't have to feel bad about considering this as an option. It's not going to increase the cost of the healthcare system. I think it's probably around the $1,500 mark per month, kind of in that range, which is sort of what the other regimens cost. Some provincial formularies are able to negotiate a special price, and so they might be able to get a better cost. But that's confidential. I wouldn't be able to know what that price is. It's kind of a confidential agreement. And then I guess,
in terms of so now, obviously lots of physicians will see Cabenuva on on somebody's PIP or documentation of their medication list. I guess for both clinicians outside in the community, family doctors, other pharmacists that may be working in the community that are not related to HIV, what are some of the things once the patient is on Cabenuva that we should all be looking for, monitoring? Is there any kind of ongoing lab work, or is that something that's done pretty much by the HIV team that's administering it? And maybe touch on some of the side effects. That would be good, because I think lots of questions will come around about on that as well.
Yeah, generally the monitoring side, the lab work, should be done by whoever is prescribing this medication. So the first thing you'd want to do is confirm that the patient is actually virally suppressed. Then you can go ahead and start them on the oral lead-in phase, if you like, for 4 weeks. And then at the end of that point, you would want to do another check for suppression before initiating the injectable. And then from there, I'd say 1 month out from any kind of med change, including Cabenuva, we like to do a viral load and see where things are at. And then from there, it's basically like any other antiretroviral regimen. You can check every 3 to 6 months to see where the viral load is sitting. In terms of anything else specific to this medication, I'd probably make sure you're getting some LFTs done, checking their renal function, just to make sure they're still kind of following, in the range where you'd be able to use this medication, and other kind of lab work like CBC, stuff like that, to kind of your usual HIV blood work that we would do. So that's nice. It doesn't kind of amount to in the beginning, there might be a little bit of extra blood work that happens, but after that, it should kind of follow the same course as other regimens. In terms of tolerability, most patients reported that it was really well tolerated. The single most high, the highest side effect that people reported were injection site reactions. So which, as could be expected with this. a bit of, swelling or soreness. And so I guess warning the patient about that ahead of time, because it's likely to happen. Other side effects that could occur, headache, nausea, that sort of thing. But in general, I think most people tolerate quite well, and most only reported the injection site reaction. So that's that's nice to know that it is so well tolerated. So maybe if you have a patient that's, we have the odd person that, even though we've got really well tolerated oral options, they have continuous nausea and they can't seem to tolerate an oral regimen. Maybe, if you can get them suppressed, maybe this is an option, just totally bypassing the oral route. That might be something that, they might get a lot of benefit from.
Okay. That makes sense. And is there any absolute reason that there's a reaction or anything that was probably, I would say, more probably in the clinical trials that they saw? I'm not sure how much post-marketing surveillance has been kind of reported for those kind of side effects yet, but is there like one of the main reasons where if I'm a clinician that's out in the community, I get a phone call, somebody's on Cabenuva and they have a reaction, I would probably tell them to go to the emergency department, but is there something that, is life-threatening or anything like that would be worrisome in this case?
I'd say if you happen to have a patient that had Hep B kind of acutely flare up, that would be a situation. If in your lab work you see that they have a detectable viral load, I'd probably jump on that and switch them to something else, preferably before, early on, before more mutations can kind of develop. Like any kind of intolerable adverse reactions. It is nice to see in the study they presented in the fall that they really didn't find there to be many hypersensitivity reactions to this medication. Okay. And then I guess as well, if the patient became pregnant, I'd probably consider, switching them to a regimen that has more safety data behind it. Right. Even though it does have kind of a long, half-life in the body, I would swap them to something else, just that has a little bit more to it. So, yeah.
Perfect. And then I just wanted to touch on the topic of the viral suppression that we're talking about. So I know when I was reviewing the monograph myself earlier this year, there's a huge topic regarding, what is suppressible viral load? So is it less than 50 copies? Am I looking at, is it, viral load not detected? I guess just for more my information. And if we don't have that clear-cut data, that's completely fine too.
Yeah. So in the trial, they put a fairly firm cutoff of less than 50 copies. So if you were 50 copies or above, they consider that, not to be suppressed in these particular trials. I know in other trials of antiretroviral therapy, sometimes they'll consider even up to 200 to be suppressed, but for these, trials, they put the cutoff at 50. So.
Okay. That's good for us to know and in terms of, I guess, getting those first initial kind of viral loads and then monitoring the viral loads, and you might've said this and I may have missed that, was once you're on Cabenuva, how frequently am I monitoring, or how frequently are you guys monitoring the HIV viral load?
Yeah, so we would do it 1 month post starting the Cabenuva injection. And then if that looks good, we would maybe do it at the 3-month mark, and then every 3 to 6 months kind of after that. Yeah. Okay. And if you've got someone who's really stable on it, especially when you're coming close to a year out from starting them, I'd probably start doing it every 6 months. Even, eventually some people might even do it once a year kind of thing. But 3 to 6 months is probably generally what you're looking at.
Okay. And I guess so, like knowing the half-life and knowing that's in your system for that long, kind of is reassuring too. So it actually, another kind of plus, I guess, side of this would be that you don't have to do frequent lab work, because right now a lot at least in the pediatric population, kind of roughly every 4 months, they're having to get pokes for blood work, and doing that from when you're a baby till your adult age is going to be, it's a drawback for sure. So
yeah, for sure.
Okay. And then in terms of, so what's can you give us some like clinical examples of patients, maybe even one example of a patient that you've managed obviously with confidentiality here, taking that into consideration.
Yes, actually, that is, we recently started a patient in December on Cabenuva, and it was because of confidentiality concerns. So she was newly diagnosed. Really, at this point, I don't know if she ever will be, but at this point, isn't really wanting to share this information with others. She does live with other people in her house, so her concern was that she has a vial of oral antiretroviral sitting around that someone might see it, Google the name of it, and find out kind of what's going on. So she was quite interested in trying this out because she's so concerned, and even in the workplace she was worried about people finding out there as well. So so for her, I think it's been a really good switch. And she was also a little bit concerned about forgetting to take her pills every day. Like, she did really well in the first bit and she got suppressed very quickly, but I think long term she was thinking day to day, super busy with other things, she could have some misses. So she kind of wanted a less, I guess, involved kind of regimen, and just get the shot once a month and forget about it until the next appointment.
Okay, that's fair. And then, so basically kind of the ideal or the most eligible patient is that someone who is virally suppressed, obviously for many years, would be preferable, right? Because then probably somebody who doesn't have too many comorbidities in terms of like the renal dysfunction that we talked about. And then the ideal patient in a lot of our clinics would be the ones that we worry about non-compliance and that type of thing. So obviously more of a structured setting, they would get the injectable and then be able to live their day-to-day life and don't really want to do blood work frequently and all that. So that's kind of what I'm understanding, which is a huge already like significant advantages, right? So especially dealing with chronic conditions like HIV, like we're aware of, there are people, it's tough. Like you don't have the ability to, as much as you want to live like your normal life. I think HIV medications have revolutionized that over the years, and we're grateful for that. But definitely if we can get towards, even decreasing all of those drawbacks of taking medications, blood work, etc., I think we're winning. So that's
moving towards improving, just quality of life, not having to focus so much on, taking pills every day. I know some practitioners, the tendency with this injectable form is to think of some of their patients that they've been struggling with adherence. They're thinking, okay, if we can get them on this, then we can keep them suppressed because they only have to come in once a month to get the injection. But I would definitely say to caution around that idea, just because, they are going to have to be suppressed before you can actually even start the injection. And then you do have to be able to get a hold of the patient. They have to be reachable. So that involves, having some, access to a phone or a computer or something, and so that you can follow up with the patient. And the real risk is if they aren't coming to their appointments, you kind of have a 7-day window where you can give the injection from let's say January 10th as your treatment date, every month on the 10th. You're supposed to come in for your injection appointment, and then you have a bit of a 7-day window to work with, that you can still get the injection. If they go outside of that, though, then you're starting to risk, that 2-class resistance I talked about earlier, which can really limit your options. You still have some NRTIs to work with and the protease inhibitors, but who wants to be on a protease inhibitor anymore? You don't have to be.
Exactly, right? Yeah.
So,
and you don't want to lose that integrase inhibitor class. So, I mean,
exactly.
We know that those drugs are great. So, yeah. No, that's fair. Okay. And then in terms of, I guess, if there's any like kind of other clinical evidence that you want to share with us today, that would be helpful too. Anything that, we didn't touch on today.
Yeah. I'd say there is one trial going on called the MOCA trial, and that is in the 12 to 18-year-old cohort, and it's going to be presented at the IAS conference in July this year. And there's going to be a special PEDS workshop that they're going to be presenting this at. And mostly, I think the information they'll be sharing is around the PK data, the safety, and the acceptability results. So I think that's definitely something that we'll all be looking forward to seeing, because it seems to be we're always kind of limited in our options for our pediatric population. So any kind of new things that kind of come along that might be options are welcome, I think. So
yeah, no, that's exciting. I'm really, really excited to see where Cabenuva is going to take us, especially with HIV care here in Saskatchewan. I think it's something that is important because we know that we've had an increase in the number of our cases, compliance definitely, because we have a lot of remote rural areas. So access to healthcare is a challenge. So I guess the last kind of thing I want to touch on is, it might be different in different centers, but here in Saskatchewan, which you're probably more familiar with, is this something that can be done at different sites? So like, is Regina and Saskatoon doing kind of the injectables, or is it something that the patient has to be referred to the ID group here in Saskatoon?
Yeah, so the Regina ID group is using it there, and I think they have a pharmacy that they have a bit of a relationship set up with, who is kind of trained about this medication and monitoring it and administering and everything like that. So they have something kind of set up there. And in Saskatoon, we just recently set up with a community pharmacy that will kind of offer patients, if you technically in Saskatchewan, you can go anywhere to receive your antiretrovirals, but the fact is that this medication is a bit different, and whoever's kind of involved in the administration of it is going to have to kind of have a special know-how, to get it to the patient. So we're kind of working on increasing locations that patients can access this. We have, started patients off with a first dose with our clinic staff, but like you said, we're facing, ever increasing numbers. We don't have enough staff to kind of deal with the present situation. So to add in something like this probably wouldn't be feasible for us. So I know a lot of other centers in Canada are kind of facing the same situation. So with the CHAP group, it's kind of been a hot topic, and people are asking, how are you rolling it? How are you rolling this out? And what are you guys doing? And it sounds like a lot of people are looking to community programs. Some places have infusion clinics, and so people who have, RA and they're getting those TNF inhibitors, they're kind of approaching those places too, because they kind of have beds and things set up for administering medication there. So those are some places. I know in Toronto, they've got a very special program where they offer the service to actually come to the patient's home and administer the injection. So that's a pretty cool idea. Obviously you have to have the resources there to do that. That would be the ideal, bring it right to the patient. But so that's kind of how we're planning to roll it out, just kind of connecting with some community partners and making sure that they're kind of up to speed on this medication and how to obtain it and that kind of thing.
So lots of new exciting things. I think Cabenuva, and since it's been on the market and coming into formulary, something that we'll probably see become more familiar with over the next few years here. So I think the underlying thing for, because we have a vast audience across North America, but especially across Canada, I would say, if there is a patient that is eligible, kind of what we talked about today, reaching out to the infectious disease group in that center, discussing with specific HIV pharmacists in that center would be a good approach, initial approach to see if they can get some more information if that patient is eligible, and that type of thing. So I think that gives me a lot of information for sure. I think I learned a lot during this episode, and I really want to thank you, Carley, for taking the time out today to come on the podcast. It's, an initiative that we started to help clinicians, pharmacists, family doctors, pediatricians, infectious disease specialists, microbiologists to really just bring out hot topics like Cabenuva, because a lot of us don't have the time to sit and, discuss all of these things with our pharmacists who are super educated on this topic compared to a lot of us. And so I think, bringing it all together in one episode here was something that I was looking forward to doing. And I think you did a fantastic job. So thank you so much for educating us today. And we'll definitely, I'll be in touch with you for sure regarding future updates on this, and maybe in the next few months to years we can kind of see what other case studies, case series, or RCTs that come out of using Cabenuva.
For sure. Yeah, thanks for having me. I'm always happy to share info on new things that are coming out in this area. So that's great.
Thanks.
A special thanks to Carley for joining us, and thank you, Dr. Purewal. Follow us on Twitter at CA Breakpoint, and email us at thecanadianbreakpoint@gmail.com to suggest infectious disease topics or discussions you'd like to hear. We look forward to seeing you again at the Canadian Breakpoint.